It is 1:30 on the dot. Good afternoon, everybody. I am Jana Broughton. I am a quality improvement advisor with Superior Health Quality Alliance, and joining me today are my fellow QIAs, Jessica Hinkle, Amy Magner, and Patty Leonard. And today we're going to be talking about, we're going to continue our conversation about the F tags related to infection control. And today we're going to talk about three. We're going to talk about F883 and F887, which are your vaccination tags. We're going to talk about F945, which is staff competency related to infection control. So this is being recorded today, and those recordings should be available shortly out on the internet. I believe our first is complete and out on our YouTube channel. If you would like to see or you've missed a week, please just drop one of us an email. We'll make sure to get that link out to you. And again, this is meant to be interactive. So if there are any questions or comments that you have about the content, and it's at an appropriate time, I will interrupt the speaker and we'll ask the question. This is for you to learn and for us to learn from you as we interact about topics relevant to long-term care and nursing facilities. So with that, I am going to go ahead and get started. All right. So for the objectives today, we want to make sure that we understand the requirements for F883 and F887, influenza, pneumococcal, and COVID-19 vaccinations, to identify required record keeping for the vaccine program, and to identify and be able to implement the requirements for F945, infection prevention and control education and training. And which one of you is going to get us started today, ladies?
Me.
All right, we'll turn it over to Patty. I'm going to go ahead and go on mute, Patty.
All right. Hey, thanks, Jana. Welcome, everyone, this afternoon. So we're going to talk to start out today about immunizations. So if we can go to the next one, Jana. So when you look at the regulations for the F883, and that is for the influenza and pneumococcal vaccines, it talks about facilities are required to develop policies and procedures regarding the administration of these vaccines, but you also have to implement the policies and procedures. And one of the requirements that you need to include there is that residents receive education about these vaccines, and that you make sure that you offer them to every resident in your facility, as well as administering them to the residents that consent to them. And we'll get into that a little bit more in a minute. As well as the F887, which is the COVID-19 vaccination, also has a requirement for staff in the regulation. So if you want to go on, Jana. So there are many similarities between these two F tags. They both talk about the development of policies and procedures. They both talk about offering the vaccines to residents, providing the education, but they also include the ability for residents to refuse. And there are also times where these vaccines might be contraindicated or might already have been administered. The vaccine education for residents and their representatives, and then the documentation is key for all these different steps that you have. The additional requirement under the COVID vaccine is the education and offering the COVID-19 vaccine to staff. Next, please. So you're going to want to build an immunization program, and I'm going to assume that you already have some kind of a program in place. I do recommend that you have somebody that's overseeing this program, somebody that knows and will do the necessary tracking. They need to make sure that your policies and procedures are approved by your QAPI team. They involve your medical director in their development, that they're kept updated with any changes in the guidance, and that you stay up to date on that guidance. Anytime you're giving a vaccine, you also must have physician orders for that vaccine. You need to make sure that your documentation in the medical record for each resident is in place to prove that the resident received the education and was offered the vaccine. So most facilities will have a form that has a place where you can consent or decline. Now, when you're admitting residents, the expectation would be that you go into your state registry, you ask the resident, and you determine and identify which vaccines the resident needs, and then you follow through and offer those vaccines to each resident. And then obviously we talked a little bit about the staff COVID vaccine requirement that needs to be built into your program as well. So you're going to have part of your program that deals with your staff and then part that deals with your residents. And many of the requirements are very similar, and they all require that you have the documentation to show and be able to prove what you're doing so that you're in compliance. So the immunization regulations, interesting enough, we went to the state operations manual, and I'm going, I can't find these regulations. Well, they haven't been put into the state operations manual. We reached right out, or just reached right out to CMS. And right now, the first statement is from them that says they're only located in the surveyor software and will not be Appendix PP. You will find them in the QSOs. And so I linked them here for you in case you want to read them again. I know we all read them way back when they were issued, but it was a nice refresher to go back into them again. So what citations are we seeing for the F883 and the F887 tags? Most usually they're at an E or a D level. Minnesota, out of our 3 states, seems to have more citations. Michigan and Wisconsin, about 3 to 4%. We did this look back probably about a month or so ago. And the citations read many different things, but failure to administer as consented for. So that would be a resident that consented to receiving any one of these vaccines. And when the surveyor reviewed the medical record and the medication administration record, the resident never received it. Sometimes it's because the paperwork got lost, nobody tracked it, it got filed and nobody knew about it. Could be for various reasons. And then sometimes there's problems with the consent form themselves. The wrong resident representative signed it. The consent form has been incomplete. Also, some facilities just didn't have an immunization program in place. They didn't offer the vaccines when they were due. And they didn't offer them again with the change in guidance. And that would apply right now with the new COVID vaccine that's been recommended for persons over the age of 65. You need to go through the whole process again and make sure that you're offering those vaccines to all your residents and staff. And failure to document the administration can also be cited as well. So it's fine to give it, but you need to be able to prove that you're giving it. It's a medication. You need to have the order and it needs to be documented in your EMR. Those of you that have an electronic medical record system often have an immunization tab, and it should be recorded there as well. And oftentimes you'll say, well, gee, I know I told them all about the vaccine. We talked about it, but you can't prove it when the surveyors are looking through the medical record. So somehow you need to figure out a way, whether or not it's to include a copy of the vaccination information sheet that calls the VIS, or however you're going to do it, but you need to be able to prove that you've done that education, especially when your residents are refusing vaccines. You need to have a good process in place to check the state registry, and oftentimes that's not done. And then sometimes citations were given for residents that received additional flu vaccines, for example, or an extra dose of the pneumococcal vaccine that wasn't indicated for. And then the F887 facilities have been cited if you can't prove that you've educated your staff and offered them the COVID-19 vaccine. Again, that's all in the maintenance of the records. So here's some best tips to prevent these citations, and we've probably talked about most of them already. But again, making sure that your resident's medical record contains that documentation and the education, and that your consent form is complete for the residents. And then if the resident is refusing or the vaccine's contraindicated, you need to indicate why. The vaccine's already been given, they're refusing, they have an allergy. And sometimes I've read citations for the vaccine wasn't given because hospice said they didn't need it. And what hospice person said this? Was it the aide or the nurse? And they in general don't give it. So you need to make sure that your process and your policies include offering the vaccine or talking to the physician, the hospice provider. And if you're not going to give it, you need to have really good documentation, the rationale for that. You can go on, Jana. And here's some more compliance tips, making sure your policies and procedures are based on the current guidance, making sure that you're checking with the advisory committee on vaccines and immunization practices, as the ACIP, to make sure that your policies and procedures are up to date. Again, I talked about one person to coordinate and oversee your program. Some facilities also have tracking records, log sheets, Excel spreadsheets, whatever it takes so you know where you're at with the administration, who's due, who's had it, who wants it, a process to look at, review all your residents' admissions for what vaccines are due. Look at your process and your procedures for your new hire onboarding, making sure that they're offered the vaccines, that staff is offered flu vaccines as well as the residents and the COVID, tracking and maintaining your acceptance and declination forms, maintaining your relationship with your pharmacy. Who are you getting your vaccine supplies for? Within a month or so, when I was a DON, we were ordering our flu vaccines. So you need to be able to know how many residents you expect to have in your buildings at those times, maintaining those relationships. Don't leave it to the last minute and then find out that there isn't any vaccine available. New facility assessment's going to come out, and I'm going to assume that there's going to be a big component in there about assessing your ability to administer vaccines and protect your residents and staff with that requirement. And then you need to also maintain those records that we talked about. So we can go on. Auditing for compliance, you can use the surveyor critical element pathway. There's a component in there on immunizations. I used to just do chart audits, randomly pick some resident charts and look through, just start from the get-go. Is the consent there? Is it filled out completely? Was the vaccine that administered ordered and administered? And then was it documented? And then do the same for your employees. Check to make sure that they've been offered. You can prove they've had the education, and that if they received the vaccine, that you have record and confirmation of it. And anytime you identify any gaps in your performance, put it through your QAPI program and develop a plan to correct that. Your entrance conference worksheet for surveys under number 29 will ask for your policies and procedures on your influenza, pneumococcal, and COVID-19 vaccinations. We can go on to the next one. And your quality measures. There are components into the MDS, as well as we know that CMS tracks your vaccine administration through the NHSN data. But the quality measures, as we know, are broke out into short stay and long stay residents, and they will ask, based off your MDS coding, you'll get a number, a percent of compliance for this, the percent of short stay residents who needed and received a flu shot for the current flu season. And it goes on percent of healthcare personnel who received the flu shot. Your long stay residents is the same. And then they also want to know about your long stay residents who needed and received a vaccine to prevent pneumonia. And those words are taken right out of the CMS guidance and the MDS reporting. So are there any questions for the vaccines? If not, I'll pass it off.
I don't see any questions, but I will share that Superior Health does do NHSN office hours. And yesterday was the date that facilities had to have had their influenza documentation for healthcare personnel in and submitted via NHSN. And for your quality payment, which is probably something that your administrators and MDS nurses look at, they are now utilizing the immunizations for residents and staff, I believe, as part of the quality measures as a payment measure. So you might want to look at that and have that conversation with your team.
And I also will mention, and maybe I'll try and find the link for this. Superior Health does provide vaccine assistance. So if you are struggling to get vaccines to your staff, especially the COVID vaccines, but this is for staff and residents, we have the ability to set up a clinic for you.
Yep.
No charge.
All right, Amy, I believe you are up.
I am. So Patty had, she briefly talked about compliance. And so in order to meet compliance, um, you have to validate competency. So as we talked about, FTAG 945 um, involves staff competency. So it's an important role as an infection preventionist is to validate staff competency. And so sometimes there's a confusion between what is competency, what is compliance, what is training, and how does that all intertwine with each other. So it's important that being competent actually means that your staff could actually do the skill or the job that they've been hired or to do or as part of their job role. So when we talk about competency, it's really important that you understand that competency should define expectations of each person's position, identify measurable and observable knowledge, skills, abilities, and behaviors, which I'm going to talk about those in the upcoming slides. And they should also describe the work of your organization. Now, competency should be evaluated for all levels. It's not just for your novice or your beginning staff. It also includes your proficient and your expert staffs as well. So competencies for all staff members should be evaluated on a regular basis. Then, according to your federal regulations, long-term care facilities must have sufficient staff with appropriate competencies. So it is your responsibility to make sure that you are validating your staff's competencies and that you are able to provide evidence and substantiate that you have validated those staff skills, especially in nursing homes and then related to services, because they want to make sure that your staff is able to attain and maintain those high practical areas of physical, mental, psychosocial well-being of each of your residents. Next slide, please. So when we talk about competencies, there actually are many different types of competencies. If you ever looked up a competency, there you find a whole list of them. But actually, for the purpose of this presentation, I really want to talk about 3 primary competencies in general that you as an infection control preventionist would want to know, and that would actually have an impact on your infection control program. So the first one is your core competencies. So when we talk about core competencies, these are actually qualities, knowledge, abilities, and behaviors that are required for your employees to perform at their best. They define what makes employees or your organization unique and irreplaceable. Core competencies are specific to each person's job responsibilities. So these are specific to what task your employees are required to provide or complete. So an example would be safe injection practices is a nurse core competency. Let's say pericare, it could be a CINA core competency, and cleaning and disinfecting of high-touch surfaces may be an environmental service core competency. So when we talk about those core competencies, they're actually created to make your workforce stronger and to meet the job-specific goals and improve your resident care, in turn promoting positive outcomes. So when I talk about competencies, especially with core competencies, I'd like to use the equation skills plus proficiency levels equal your core competencies. Again, these are for employees for specific roles and tasks that they are required to complete. So you want to make sure that they're able to perform those tasks. Then there are the organization core competencies. And so these are actually essential for all employees. These are not singled out to a single group or department. So like I mentioned, CNAs, nurses, environmental services, where those are actually more to each department. This, when we talk about an organization or your facility competencies, or maybe even a corporate competency, these actually are about all employees. So organization-wide competencies are selected to achieve an organization or your facility's strategic goals for all staff. And this could be like your hand hygiene or fit testing. Like all staff should be validated that they can actually perform the task of hand hygiene, or they're able to put on a N95 for fit testing. So again, those are just part of that organization core competency that you would be responsible for. And then the third and final competency that as an IP that you'd want to focus on is our behavioral competencies. So these competencies are used for individual tasks, for skills, knowledge, and qualities that are unique to assigned roles. So when we talk about behavioral competencies, we are actually associate those to areas such as like leadership, adaptability, conflict resolution, time management, and customer service. So unlike those core competencies that place emphasis on technical skills, which are the specific knowledge and abilities required to do the task, behavioral competencies are applied to the attitudes and behaviors that determine how someone actually performs their job. So as I mentioned, competencies are that measurable patterns of knowledge, skills, behaviors, abilities, and behaviors. So when I say knowledge, I actually mean that's information that's developed or learned through experiences or studies. So the staff is actually obtaining that information that you're providing to them. So that would be, again, that knowledge, what you're teaching them. And then skills is actually the result. So the skill is being the result of repeatedly applying that knowledge or task. So when you provide that knowledge, then you want to be able to see, can they actually perform that skill that you taught them? And then abilities refer to an innate potential, meaning to perform mental or physical actions or tasks to the best of your staff's abilities. And then behaviors, which are the observable reactions of an individual to a certain situation and other characteristics that that individual needs to perform their job successfully. And it's those behaviors that will actually sustain your compliance. And then knowing what your staff competencies are is important because it is the level of care that your residents will receive. So you want to make sure that your staff are able to provide care according to regulations and whatever your policies and procedures are put into place. You want to make sure that their care, the competencies that reflects that care that's being provided. It's also important that you know that when a surveyor presents to your facility, so this is where we look at the F945 tag. Surveyors must determine through information obtained by observing and interviewing your staff, as well as verifying and reviewing employee records, whether the facility actually employs competent staff to provide care, and then services in assisting residents to attain and maintain that highest practical level of physical, mental, functional, and psychosocial well-being that I mentioned. So again, you want to make sure that you are validating the competency of your staff, that they are actually qualified to perform the tasks that you've asked them to provide or perform. So when we talk about staff competencies are necessary to provide the level and types of care needed for each facility's resident population. So again, those competencies would be specific to your facilities. They also validate that all staff, that includes managers, contracted staff, it also includes agency staff. So you should be validating the competency and compliance of your agency staff as well. And if you have volunteers in your building, you want to make sure whatever skills they're actually providing and demonstrating are actually validated. And then you want to make sure that all those individuals have been educated and trained appropriately according to current regulations, standards of practice, and their skills meet the requirements carried out that you require from them and for them. And then finally, competencies also equate to staff skills and their proficiency levels. Next slide, please. And so I gave you just a diagram, it's a simple diagram, and this is the competency process. So when we talk about those competencies and the process and how they align, and one should follow the other one simultaneously. So understanding staff's level of competency requires that you understand this competency process. So when we talk about competencies, they actually encompass an individual's ability as they relate to, or as I recently stated, knowledge, skills, attitude, and behaviors. And then what they do is we combine those, all those skills with relevant personal characteristics. And we want to make sure that your staff can successfully perform the jobs and their roles. So remember, competencies describe the observable and measurable. So we want to be able to observe the skill as well as measure it. And then their key behaviors and actions that we see when the job is actually being done. So when we talk about knowledge, so knowledge is that first step in that process. Knowledge is achieved by providing education or information that helps staff develop or learn through those experiences and studying. And knowledge is also the understanding of information that is applied directly to successfully perform a task. And then skills is the result of repeatedly applying that knowledge or the ability to do something. So skill is actually performing a task. So a person can learn a skill through education and obtaining that knowledge in that first step. But just because someone is taught a skill does not necessarily mean that they can actually do the skill. And that's what's important to understand. Just because you give that knowledge to somebody doesn't mean they can actually carry that skill out successfully. So being skilled does not equate to excellence. Important to remember that as well. And it just means that staff knows how to do something, but to excel in a specific role or skill, a person actually needs to be competent. And then the third step is abilities. And that third step, this is where staff's abilities to perform the task or skill that is necessary to perform the job resulting is an observable outcome that you can actually observe your staff member providing that skill and what is that staff's ability to perform that skill, Although abilities can easily be confused with skills, we must pay attention to the detail that helps understand the difference. Abilities are actually a combination of a person's skills, their knowledge, and their capability to carry out that skill successfully and will promote positive outcomes. And then behaviors is the last step in that process. So behaviors are actually the observable reaction of an individual to a certain situation. So behaviors determine how a person will effectively or ineffectively perform a task or job. So basically, are they going to do what's right, or are they going to do what's easy based on time constraints? So when we talk about behaviors, it's the competency of compliance will be carried out based on your staff's behaviors. So your staff can be provided the best knowledge, they demonstrate their skills effectively, they have the ability to carry out excellence, but if they don't have the behaviors to want to carry out those education and the skills according to regulations and policies and standards of practice, that will have a significant impact on your compliance. So when following the competency process, the combination of each of these steps actually will lead to superior performance. Next slide, please. So when we talk about competency and how do we evaluate a staff member's competency, a successful competency assessment begins with knowing the difference between a competency check and an observation audit. And so a part of our TRQI work is that those are the two tasks that we often will speak to our homes about, and we have those conversations. And we often find there is a lot of confusion between what is a competency check and then what is an observation audit. So I just want to make sure that I just briefly explain the difference between those two if you're wondering what the difference is or if you have any questions. So a competency check is actually the evaluation of an individual's skills, their experience, and specific competencies against their job assignments and duties. So a competency check could include skills tests, interviews, maybe you have some type of task-based testing, or even a return demonstration. The overall aim when you're doing a competency check is to generate enough information to determine if a person can perform well in their role, assess their skills, and then determine performance levels. So it's that competency check that will actually, you will validate if your staff is going to be able to provide the task accordingly to your current standards of practice, regulations, and they'll carry out the job that you asked them to do. Well, an observation audit actually applies to gathering or collecting evidence that substantiates that either staff can or are not demonstrating efficiency in a specific skill. So when we talk about an observation audit, it is used as an objective evidence. So objective means you can actually see it happening, you can actually validate it, and you can actually prove it. Which this allows the opportunity to communicate audit results, identify gaps, and then suggest areas for improvements. So when performing a hands-on competency assessment as an IP, you will want to develop and utilize a competency assessment tool or checklist that you can use to guide you through that assessment process. Again, you want to make sure that if you are developing your own competency assessment tool, that you will actually align that to whatever your facility's policy and procedure is, because that will support your infection control program. And then I do encourage an assessment tool when you're doing an observation, because it does help guide the observation and it keeps whoever's doing those observations on task. And then competency assessments should be performed annually or as needed, and they should also be announced or unannounced. So I always tell facilities that unannounced competency checks are actually will give you a better accuracy in your staff's work, especially when staff know they are not being watched, because they always, staff normally will do the right thing when they know they're being watched. It's when they're not being watched that will be the true determination if they're following through accordingly. And then competency assessment should not only be done after education and training has been provided, but you should be checking your staff's competency whenever you introduce a new skill, whether there's a change in the skill or a process has occurred, if you introduce a new piece of equipment, or if there are any other education any other education or training that needs to occur. You want to make sure anytime you introduce any new skill or it's going to require education for a skill that you are validating your staff's competency as well. And then along with performing visual observations of staff demonstrating defined skill, a great example would be hand hygiene. So in the event you observe incompetence during a competency assessment, then you could actually provide some education and remediation in real time. And then finally, upon completing a competency assessment, both the observer and the staff member who observed should actually sign and date the document stating that the observation was completed, that the staff was competent, and then that should be, that documentation should be placed into your staff member's file with HR. Next slide, please. Because if a surveyor comes to your facility, they're going to want to make sure that you're able to validate that your staff is actually compliant. So you want to be able to show that the observation was actually done when it was done. As I stated, that with core measures, there are some core measures that need to be done on an annual basis. So here on this slide here, I actually I provided you with a hands-on competency assessment. We did put the link to this actual checkoff list in the chats section. So I do encourage you to use, as I stated, a checkoff list. It will guide you through the observation process. It's very simple. This one is very simple. It's very straightforward. So you just go through that checklist. And when you use a checklist, it also helps that you don't miss any steps as well. And so for a staff member to be validated as competent in a skill, they should receive 100% accuracy. If they don't, then it's up to you how you want to approach that situation. So you can either do remediation, re-education, but however, if you have a staff member, you go through the checklist and you find that they're not competent, I would definitely encourage you to re-educate your staff, and then I would reevaluate their competency again. Next slide, please. It's important that you understand as well why competency assessments are needed and need to be completed. As I often say in my own practice as a nurse, I need to understand why I do what I do. So therefore, it is important you also know why competency assessments are important. Not uncommon that we speak to infection preventionists and they will tell us they haven't done any competency evaluations or audits in months. And it's surprising. So it's important that you understand why they are important. So a competency assessment helps to identify any gaps in your staff skills. So whether that skill is a technical skill that applies to each person's individual role, or if it's an organization skill. So whatever skill that's going to impact your facility, you need to make sure that you are assessing that your staff members can carry that skill out accurately. With a competency assessment, it also identifies, again, gaps. So then you are then able to support those individuals by providing re-education and remediation, and you want to make sure you're able to do that in real time in your attempt to catch the problems early. So I do encourage you, if you identify that a staff may be performing a task, and sometimes I think when we do competency assessments, we'll identify that the staff didn't carry out the skill accurately, or maybe they kind of got it right. You want to be straightforward, because if you don't correct them in that real time, they'll continue to just make the same mistakes over. And then eventually that will hinder your facility. You could be cited, and it doesn't help your staff members as well. So then a competency assessment is also important because it helps to identify your staff's strengths and then areas of growth. It also helps to identify specific areas needing improvement, which will allow for the ability to develop individual or facility improvement goals. And then finally, a competency assessment can validate or aid in improving overall compliance in the delivery of resident care within your facility. And then as an IP, you play an essential role in validating staff's competencies and how your staff's performance is actually impacting your facility's infection control program. Competencies and staff members, their skill sets must be evaluated. You should be evaluating their skill set on hire as part of the new hire orientation process annually, as I stated. And then as I also stated, whenever there are any changes in your facility's organization policies, procedures, and practices. Infection control competency should reflect the expectations described in your facility's assessment. And then to avoid that F945 tag, a facility assessment must address or include staff's competencies that are necessary to provide the level and types of care for that resident population that you care for. And then as an IP, you should have a plan. It's important that you have a plan involving how you will evaluate your staff's skill performance, and then determine objectively to their level of understanding. And you can easily do that with a simple checkoff list like I provided. Next slide, please. And then just so you understand the approach and the process when we talk about that knowledge, training to compliance, how do we get to compliance? So a systemic approach to competency-based training is for best practice is to ensure sustained compliance. So a competency framework, just as the simple process, something that I provided here for you, This is an integrated method to accurately assess critical gaps in skills and validates ongoing proficiency. So in order to successfully achieve proficiency in any skill, education must occur first. So you see that's education, training down at the bottom. Education and training is provided with staff. So we provide them with the knowledge that is needed to carry out a skill. And education equates to learning. It's in this phase the learner obtains the knowledge required to demonstrate the skill. And then when we talk about education, we then want to incorporate training, which training is actually the act. This is where they're actually carrying out that knowledge that they've been provided. And then once a skill has been taught and demonstrated through training, the next step in the process is to validate the staff's competency regarding that skill. It's in this phase where the skill is successfully carried out and then contributes to the staff's effective job performance. Competencies involve staff taking the skills, knowledge they've received, and then applying their behaviors and attitudes, successfully carrying out and sustaining that compliance. And then compliance actually means adhering to the standards or regulations to simplify doing what is expected and required to do in order to meet the desired outcomes of that skill. It's important to understand that compliance is a choice. So once an individual is deemed competent at a specific skill, it's going to be their decision if they want to remain compliant. So even though you deem them competent in that skill, it's going to be up to your staff's member if they want to remain compliant with that skill. So it's going to be up to you as the IP to make sure that you are validating that staff's compliance on a regular basis. And then, as I stated, compliance refers to the practice and behaviors of your staff that meets the expectations and professional standards set by your facility. And then compliance also involves regular audits, reviews, education, investigation, and risk monitoring. And then compliance helps to address poor practices, gaps in care. And it's also to remember when you're validating compliance that you also celebrate your staff successes.
So I think we're going to take this opportunity to pause. There was a question in the chat about, or in the Q&A about vaccines and how soon you would have to give them after admission. I don't know, Jana, if you want to elaborate on that.
Sure, I can do that real quick. I appreciate this question because I know this is it's one of those areas where you want to be great customer service and you want to be so resident focused and you recognize that they're healing, they're coming in for a wellness, a spell of illness. However, I said in the note back that best practice would be to at least approach them about their vaccine preferences, approach them about their awareness of where they're at with their vaccines, and get their ability, get their permission, the forms filled out regarding whether or not they desire to have vaccines, and permission perhaps to look up in MICR or your state registry to see what's available or what they need. Sometimes residents, because they've been ill, have not been able to get out or get access to vaccines. And when they're in the facility, it's a great time to help them get caught up, and that is a good customer service to provide that for them. Anybody else want to chime in on that one?
No, I think you need to, as Jana mentioned, be able to show that you have assessed their need for vaccines and then demonstrate that you provided that education. And perhaps it's something you would do at discharge and make a note of that.
Yeah. Any questions about Amy's presentation while we've got this little break before we move on? Amy, thank you so much. That was great, very helpful. The competency, just so folks know, the new regulations or the new defined or refined regulations around the facility assessment are going to play into the definition of staff competency and looking at the number of staff needed to provide certain levels of care. So this is a very timely discussion topic for you as IPs to be aware of the expectations in the regulations around competency for your staff with specific tasks or roles. So on that, Jessica, I think we're going to turn it over to you because I don't see any other questions.
It was Alicia added to the chat for MDS. It says they said I have to give flu and pneumonia within 4 days for quality measures.
That is correct. That is something that you should be doing. It's not within 4 days. I'll have to look at that to validate, Alicia, but it is a short-term stay quality measure about offering the vaccines. And that goes back to your quality payment measure. The facilities can be dinged on their payment measures related to vaccine timeliness and the offering of it. I would encourage you to work directly with your MDS nurse on all sorts, or your MDS director on these different tasks and problem solve around how you handle vaccines and documentation of infections. So we can chat more about that. And I think that QRP discussion is something we probably need to add to this so that infection preventionists understand their role in the quality measures. Okay.
All right, Jenna, you can advance to the next slide. So if we look at F945, it talks about needing to have that written plan for staff education. And it's a lot of words to say that basically you need to have a plan that's effective as determined by staff need. You can flip to the next slide. So when they talk about staff, and Amy touched on this, who is staff? And that's going to be all your direct and indirect care staff, any contracted staff, including agency travel, pharmacy, therapy, any other contracted services that might be providing that hands-on care with residents, and your volunteers. Next slide. So when you think about effective educational programs, that's a wide range of people to be educating, and they're not all going to have the same needs, and they're not all coming from the same level of education. So for each group, you have to explain your objectives and really generate that environment of teamwork. And I know that there are some topics that we are training staff on that are frustrating for us, that are causing us grief. And one of the most important things I think that we can do as leaders is to model the behavior that we are teaching. So let's take enhanced barrier precautions for an example. We do have the obligation to teach staff enhanced barrier precautions. Everybody's very frustrated about it. So when they hear you teaching them to do it, but also hearing you teaching them about how frustrating it is, it creates a cognitive dissonance. And so you really have to find the best positives you can out of the situation and teach from those. And that's true with everything. If you're telling staff to wash their hands, but you're walking around the building and you're not washing your hands, that's not showing them what you want them to be learning. Offer training with alternative shifts and schedules in mind. Expecting third shift to wake up in the middle of their sleep day to come in for a meeting is probably not practical. You wouldn't expect first shift to come in the middle of the night for training. So having a video that they can watch to get their training in, or doing trainings on third shift, just keeping those alternative shifts and schedules in mind, and then making sure that you have the floor covered so that when your staff is attending an in-service, they get to attend the in-service and not be pulled for call-outs. In this mix of people, you're going to want to employ a variety of methods for training. You might have some written, some video, in-person, hands-on, role-playing, training exercises. I've heard of, Amy talked about doing escape rooms. You're going to have people that love creating fun around learning, and you're going to have people that want a didactic book to read and a test to take. And so you have to consider all of those different avenues and kind of vary your training methods to meet everybody's needs. You also have to consider, if you have people that have language or reading barriers, how are you going to still train them effectively? So that's where you have to adapt to backgrounds and learning styles. If you have somebody that is doing a computer learning training and they don't know how to use the computer, all of their energy is going to be wasted on learning that computer and that tech skill, and they're not really going to learn what you need them to learn. So if you're going to expect people to use technology to train, they really need to learn that first and be competent in how to do that before you're able to teach them on that method. Otherwise, you'll have other people logging in and completing their training for them. And validating understanding is a very important step. And I'm going to use this not education related scenario, but one day I noticed that our storerooms were getting packed full to the ceiling. And so I put in a work order to have maintenance put a tape 18 inches from the ceiling so that staff knew where to stop. And weeks go by and I walk into the storeroom one day and I look up and there are probably 40 or 50 tape streamers hanging from the ceiling. So they're all up here. It had to have taken him hours to do this. He measured out enough 18 inches with a little lip to hang them on the ceiling. He did exactly what the work order said. He didn't do it wrong. I said what I meant, but we did not understand what the other person was saying. And so that's really one of the most comical things I can think of from my career, is walking in thinking they were having some kind of party in the storage room, but that was his way of putting tape 18 inches from the ceiling. So just validating that what you're saying is how it's being perceived by the learner. And provide opportunities for questions and concerns. You really need that feedback from your staff, because if they're not understanding, or if they're coming up against barriers and they're not able to talk to you about those, they're going to do it wrong, and they're going to do it wrong in front of a state surveyor, or they're going to cause harm or potential harm to your residents. So, and then looking for future content, what things are new as they come out. Staff are going to come to you with questions, and then you will learn where your knowledge gaps are from your frontline staff. So if you look at the minimum requirements listed for infection control training, these are the types of things you'll find. But what you kind of have to know about the state operations manual is that there are nuggets of what you need to train about throughout the entire manual. So we're going to talk about things in your training programs. You're going to talk about spread of communicable disease, how to identify, report. You're going to learn about occupational health. You're going to train staff to know when to let you know they're sick, when they can come back. You're going to go through transmission-based precautions, standard precautions, things like hand hygiene, cleaning, disinfection, PPE, and you're going to have to learn those infection control practices for caring for residents. You can flip to the next slide. So we'll get into a little more about what to train about, but the important thing to know is, when do you train staff? And Amy did touch on this. So you're going to train them when they start. You're going to train them annually. You're going to train them if there's a new policy, procedure, supplier, or equipment change. If there's a new health risk, for example, COVID-19. If you have an infectious outbreak of anything, a GI outbreak, a respiratory outbreak, a pink eye outbreak, you're going to have to teach them how to identify and how to respond to that. You're going to do just-in-time training when you observe somebody not doing something correctly. So they didn't wash their hands, they didn't put on PPE correctly, they didn't doff PPE correctly, they're wearing PPE in the hallway when they shouldn't be. Those are things that you're going to pull somebody aside and say, hey, I noticed this. Now, conversely, if that's all you're doing is saying, you didn't do this right, you didn't do this right, you're not going to have very good rapport with your staff. And so you also have to use those opportunities to share when they are doing things correctly. And then, of course, if you're identifying something widespread that's going on where they have a knowledge, skill, behavior gap, that's something that needs addressed in a widespread manner. So Amy talked about this. We'll go through it quickly. Skills are something you're going to learn to perform a task. Competency is when you know how to do it, and you'll be able to take a test, you'll be observed, you'll be able to teach it back to somebody. And competence is when you're compliant with rules, regulations, policies, and procedures. And you can't be compliant until you are competent and you have the skills to do it. So if we take hand hygiene for an example, you'll have a checklist for hand hygiene using soap and water, and hand hygiene using alcohol-based hand rub. And you're going to teach them, and you're going to go through the checklist. Check, 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 sign at the end. Yes, they know how to do it. Competency will show their understanding. So if you give them a test about when to use soap and water and when to use alcohol-based hand rub, can they tell you? Can they explain the difference? And the compliance, you're going to see them with C. diff patient, you're going to see them using soap and water, and they're not going to reach for the hand hygiene or the hand sanitizer. And all of these are opportunities to document your process so that you have data to show, and use that information to celebrate, re-educate, and discipline. And so when you're thinking about next steps, the just culture is really the place to be. If you have somebody that doesn't really understand how to do something, that can't do it the way they were taught for some reason, you really have to understand those. Discipline is not always the first go-to. You really have to understand why they didn't do things correctly. And so sometimes that warrants a conversation. Did they not have access? Were the supplies not stocked? Did they have too many residents to care for and they can't meet all of those residents' needs? It's really important to have those conversations and find out why before you jump to discipline. So some educational topics to include, of course, hand hygiene. We talked about most of these already. Respiratory etiquette, covering coughs. There's an amazing amount of adults that don't know how to cover their coughs or cover their sneezes correctly to keep droplets from spraying all over their environment and on their hands. Disinfection of shared or reusable medical equipment, antibiotic stewardship, occupational health. You're going to get tuberculosis, bloodborne pathogens, injection safety, illness policies, and immunizations. And you're going to do these things just in time as you see things happening. You're going to educate in meetings and huddles. You're going to do this informally or formally when non-compliance or misunderstanding is noted. Other identified areas in your facility assessment might be things that are high risk, that might be things that occur frequently, they might be things that are new to your facility, but wound care, if you suddenly start taking wound vacs, you're going to want to ramp up your education program around wound vacs. Pericare is something that is always going to be something you want to train your staff and audit your staff on. Cleaning of shared equipment, when it's moving from patient to patient, is it getting cleaned? And does staff know how to clean it? Do they have what they need to clean it readily available? How are things going in the shower room? And we do have a new shower room audit that is available on our website if you want to do some auditing in your shower room. What kinds of infections do you have in your building, and do your staff understand how they're transmitted and how to prevent transmission? If you have glucometers, are they getting cleaned correctly? Is there a barrier used? Do the staff know how to do that correctly? Catheters are something to always go through with staff because they're just a high risk scenario. And you're going to want to also train your staff to teach and model infection control to your residents and to your visitors. There's nothing worse than having staff say, you have to wear a mask when half of the staff is running around with their mask below their nose. We also have the duty to educate residents, families, and visitors. We want to make sure that we've posted signage at the entrance about hand hygiene, having that hand hygiene supply available for them at the entrance, having masks available at the entrance, having signage about cough etiquette, not visiting when they're ill, not visiting when they're exposed. We want to make sure that they know that those are important things to keep the residents and the other staff healthy. If their residents are in transmission-based precautions, they really need to understand what that means. And if they need to wear PPE when they're going in the room, they need trained on how to don and doff it just like we are. And they also need education on antibiotic stewardship and how, as a facility, our organization has dedicated time and effort into avoiding unnecessary antibiotic use and helping explain that as residents seem to maybe need one, but that we may be just watching to see how their condition changes and keeping in touch with the doctor. Residents, families, visitors, they need educated upon admission annually. We talked about the change of condition. If they go into enhanced barrier precautions or transmission-based precautions, they'll need that education. If you're having infectious outbreaks or new health risks, those are good times to educate as well. And education is a team effort. It's not just the infection preventionist that's going to be educating staff. And it might be somebody altogether that's in charge of your staff education as a whole. And typically it will be a team of people that have input into what we're going to teach staff for the year. It's going to be based on your facility risk assessments and your facility assessment. And you're going to need to know where training is required for some people, but not others. Infection control is going to be way different for a clinical person that's doing hands-on care than a non-clinical person that's working in the business office. So knowing that the training programs need to be different for those particular positions. Your managers can be used as subject matter experts and share the load in providing education and evaluating competency and compliance. You're going to want to review this education plan routinely and update it as needed. And again, offer on all types of shifts and for all types of learners, and do find ways to make it fun. And I think, Patty, we're back to you.
Yeah, back to me. All right, thank you. Just real quickly, as the director of nursing in your role, you need to make sure that your staff is competency validated and that all your new hire staff complete that checklist. I think nothing was more upsetting to me than, looking at an employee's file and seeing all these blanks on the form and they'd been there several months. Now, obviously, that was a message to me that I needed to check back with my staff development people and check on our process. And we did make some revisions to that, but you are responsible for that. And so that's something else that you're going to need to audit. And I think Jess and Amy have pretty much addressed, who's going to do your competency validation and the various content that should be in there. So I do have a question for the group though. How many of you do have like an established plan for your competency validations? If you want to stick something in chat, I'd just be real interested.
Not
Are
seeing anything in chat
nothing?
yet.
Okay, I
But-
just wondered about competency fairs. Okay, we got Relias here.
Yeah, Relias.
Yeah, what about hands-on Educare?
Yeah.
Skills Fair, yeah, I really like Skills Fair. You put a theme to it, you make it fun, you take it to all your shifts. My favorite activity was getting into the Hoyer lift, and they used to transfer me around. They got a big kick out of that. And just back to the vaccination question, we'll do some digging on the MDS question and see if we can't get some more information for the next session.
I'm going to
Which
look up the QRP question. I think that's important to talk about because that's new this year.
And we are off next week. We are attending the Healthcare Association of Michigan, Jana and I, next week up northern Michigan. But we will be back on Thursday, the 30th.
Yes, and before we go, if anybody has any questions about the content here, if you have any questions or comments or resource needs in regards to Skilled Fair, and do we have the link for the slides? Yes, we can put the slides in the chat. I will stop sharing so that I can grab them and put them in the chat without interrupting who's presenting. So thank you, ladies. This was really, really informative. I do appreciate this. I know it's a hard topic. During COVID, I think things got so crazy. I don't know, with everything going on, and we were so fixated on all of the requirements around the outbreak and the pandemic that we did not have, we didn't focus. We forgot the basics, right? We forgot about those annual competency fairs. We forgot about checking staff off. And, I've read, and I know Patty, Amy and Jess have all read surveys where the examples of facilities getting high level tags because of something negative happening to a resident and then not being able to locate education or competency for the staff in relationship to the fall from the Hoyer, for example, or failure to take care of a trach properly.
The record keeping, we maybe didn't stress enough, but that's just as important for your competencies, being able to locate that material and not having it in 3 or 4 different places.
Yeah.
Really
resources for skills fairs would be amazing, Amy. So there you go. So I know there is something in the works on that, and we have recognized that that is a big need. So in the meantime, it is almost 2:30. Thank you all for joining us today. If you could be so kind as to please complete the evaluation for today, we would greatly appreciate that. And hope you all have a great week and a half off, 2 weeks off actually, and a happy Memorial Day. And we'll see you back here on the 30th.